Welcome to The Art of Wet AMD, Drug Choice and the Latest Data, a mini-series from New Retina Radio. Dr. Arshad Khanani leads a roundtable discussion about modern approaches to wet AMD therapy with Drs. Christopher Fuller, Nicholas London, and Christina Weng. This is an editorially independent podcast supported by Novartis. Now, let's join the discussion.
Hello and welcome everyone to the first episode of Wet AMD, the Art of Drug Choice and the Latest Data. I have the pleasure of having three great faculty members here, Christina Weng from Baylor College of Medicine, Chris Fuller from Texas Retina Associates in Lubbock, Texas, and Nikolas J.S. London from San Diego. Welcome everyone.
Thanks for having us, Arshad.
Thanks, Arshad.
So this is episode 104. Today we'll discuss tactics for switching wet AMD patients to different drugs, and then also review a case with Dr. Fuller after the break. In future episodes, we'll discuss phase 3 data, pipeline candidates, and we'll wrap up the series with a discussion of safety, which we all know is very crucial in this day and age. So now let's get into our review of therapeutic options for wet AMD. Christina, I'm going to start with you first. How are you treating your patients with naive wet AMD in your clinic?
Well, Arshad, things haven't really changed given the current circumstances of the COVID-19 pandemic. I still am treating with anti-VEGF agents. I have used all the agents that we currently have available on market. And like 90% of American retina specialists, I use treat and extend. We've continued that. We haven't decreased treatment frequency. We actually haven't even reduced our wet AMD visit frequency either. But what we have done is try to streamline as best as possible in our clinics the patient's visit so that they're in and out as quickly as possible. And I think that's probably what most people are doing right now. But yeah, I feel like it's been going just as kind of business as usual, except for just a couple of minor changes in our office in terms of imaging them with OCT right when they get into the door and then working them up from the same room so that there's less contact with other parts of the office.
So it sounds like you have not changed your management, but you have changed your office logistics and procedures to keep the patient, not in the office for too long and get them in and out. So Nick, when you have a naive patient, how do you decide which agent to use? And when do you decide to switch the anti-VEGF agent you're using? And what are your parameters?
So when I have a new patient, I assess them and I make a decision whether or not they're sort of your typical wet AMD or whether they've got sort of a polypoidal variant or something else sort of unusual going on, assuming they just sort of have the typical picture of neovascular AMD. I'll typically reach for one of the branded agents first. I do use bevacizumab, but I more frequently go for one of the branded agents, either ranibizumab or aflibercept. And I do, again, what Dr. Weng mentioned, I start them off on treat and extend. I'll do 3 monthly injections and then extend them out based on how they're doing 2 weeks at a time. Sometimes I'll go 1 week at a time if I think that they didn't have a complete response or if I feel like they just need a little bit of extra medication.
So when do you decide to switch?
So I don't need to switch very often, and I typically want to make sure that I really need to switch before I do so. So I find that the vast majority of patients are well controlled on whatever agent I start them off on. So be that bevacizumab, ranibizumab, or aflibercept, or brolucizumab, most patients do quite well. If somebody has persistent fluid that is symptomatic, after at least 3 injections with a prior agent, at that point, I'll start reconsidering and I'll think about switching at that point. But I've got a pretty high threshold for switching.
All right, sounds good. And then Chris, what makes you switch to a different agent? Is it worsening fluid? Is it persistent fluid? Is it vision loss? So just tell us, what are your parameters to gauge disease activity in your patients with neovascular AMD?
Yeah, so I'm an early adopter and have been since I started practice in 2009. And I've been a champion of durable therapy. So I was immediately intrigued by Eylea when it was introduced in late 2011. And that's my primary go-to for most patients. I was kind of enamored by its Q2 dosing, which has since been revised in the packaging insert. And so assuming the patient's insurance will allow them to have EYLEA. I typically start with that unless it's a massive PED and I have concerns for an RPE rip. I will change though in cases of tachyphylaxis, intraretinal fluid, maybe less so subretinal fluid, and visual decline that's not otherwise explained. So, but I tend to be kind of EYLEA 80+% of the time for the vast majority of my patients.
So what are you doing now that you have brolucizumab available, Chris? So it seemed like you're going for EYLEA, which tend to drive the retina a little bit better than other agent. Obviously, you know, in general, in trials, in terms of visual acuity, the differences are minimal. But it sounds like you are going for that punch and trying to get that anatomy control and also durability. So with brolucizumab, as you said, you're an early adapter. Did you start using the drug when it got approved last October?
Yeah, in fact, I had been talking to my patients throughout 2019 that this new drug may soon become available. And even in, I guess, November, because I didn't get an immediate shipment of Beovu, I had samples on hand and started to kind of eagerly dispense it to my patients. And to date, I looked at my numbers today. I've done 300 plus Beovu since January of 2020 through this afternoon. So I am using quite a bit of Beovu, and we'll talk about, I think, some of the concerns about that drug later. And I have modified my criteria for choosing patients. But yeah, I'm a big fan, and it's certainly taken a chunk out of kind of my EYLEA load.
So I agree. I think for our audience, we have a safety section at the end. So the last episode is safety. So we are going to discuss all the risk and benefits of different agents and upcoming treatments at that time. Right now, we are mostly focusing on therapeutic options and the regimen. And so, Christina, for you, what are the limitations for current agents? And especially, as you said, during the pandemic, we would like to extend these patients longer. Obviously, that's not happening. And we're just trying to get them in and out. So in your sense, is durability the only limitation, or there are more limitations to these agents? What would you like to see an agent that gets approved in the future in terms of the unmet need?
I mean, I certainly think that durability is arguably the greatest unmet need in this area. The agents that we currently have are all very effective, and we're very fortunate to have that. I mean, I think they've really revolutionized the entire management of wet AMD. But the problem is that, and even with aflibercept, I'll say, you know, when you look at broad, larger studies, the durability differences between the agents are minimal at best. And so the problem is that these patients end up having a huge treatment burden, and then they're not able to keep up with the huge treatment burden. And as a result, they do end up suffering visual consequences because of undertreatment. So I do think that that's still a big issue. And that's why there's this quest right now in big pharma. You know, there's a quest to see what we can do, whether it's to derive a new compound that has longer durability because of molecular properties, or if we're trying to design a device that can elute over a long time, or even going to the next level and looking at gene therapy. And I know some of those things we're going to talk about later. But that's not the only unmet need, Arshad. Going back to your question, I do think that the imperfect ability to have effect is also an issue. So not all agents work for all AMD patients. And we've seen that. There are patients who continue to be refractory, even if you're injecting every 4 weeks. I know some of my colleagues even inject more frequently than that in order to keep their patients under good control. So I think that there's definitely still room in our toolbox for new agents, new mechanisms of action that can perhaps target other components of the pathway and the pathogenesis of wet AMD.
I think those are excellent points, Christina. I think durability is probably the biggest unmet need, but there's a good subset of patients that actually are not controlled, even with monthly anti-VEGF injections. So Nick, like what is, so you mentioned earlier you have some tolerance for fluid, but what is your, threshold in terms of tolerating fluid? And what are your criteria in terms of seeing that this patient is not controlled? Is it vision? Like if they're on monthly injection, they have fluid, they're losing vision. Is that what you look for? Or you guide your treatment based on OCT? Because personally, I mean, vision can fluctuate quite a bit in real world, especially, you know, you and I participate in the trial, and so is the rest of the faculty members here. You know, ETDRS is more accurate. Even that fluctuates and it takes time. So tell me, what parameters are you using in your practice to really figure out if this patient's disease is controlled or not? And if it's not, what are you doing about it?
Yeah, Arshad, I think that's a really good question. And that's sort of where the art of this comes in, is sort of figuring out if what you're doing is working based on the data that you have at hand. And the data, as you mentioned, you've got the OCT, so you can look for fluid, either subretinal fluid or intraretinal fluid. And I think we all have some thoughts on that, but I, in general, am more concerned about intraretinal fluid than subretinal fluid. I'm willing to tolerate subretinal fluid a little bit more. I certainly look at their visual acuity, and as you said, the visual acuity tends to fluctuate. It's what patients sort of cling on to each time. They'll say, oh, I was 20/40 last time, and now I'm 20/50 plus 1. And I always tell them to take that with a grain of salt, because as we know, that changes quite a bit based on testing parameters, the technician who tests them, whether or not they may have slept well the night before, or who knows, probably a handful of parameters that affect an individual visual acuity on one testing visit. I always look at those things, and then I ask the patient how they're doing. I think that's a very important data point that, that maybe we don't pay enough attention to. I say, are you doing well? Are you happy? You're measuring 20/40 today, which is slightly better or slightly worse than your last visit. How do you feel you're doing? And if patients feel that they're doing worse, and if the fluid's increased and we're measuring a decline on the chart, then I know that I need to adjust something. In general, I'll be willing to tolerate a little bit of fluctuation in fluid and a little bit of fluctuation in visual acuity if the patient feels like they're doing perfectly fine. It's hard to take a patient who feels like they're doing fantastic and make them better. So I add in that sort of subjective patient assessment of how they're doing as well.
I got it. And then what do you do? So, you said that you really don't switch much. So if you had a patient, let's say, receive monthly injection with a lot of fluid and 20/40, 20/50 vision, is that a sign of not good control? And would you consider switching them to a more potent agent?
Yeah, absolutely. I mean, I know when I said I don't switch a lot, it's because the agents that we use are so effective.
Yeah, absolutely.
If I start them on, Q4 ranibizumab and then do a treat and extend, they tend to do well, and we'll find out whatever threshold they need to stay at. And I'm willing to tolerate some fluid. I'm willing to tolerate some subretinal fluid as long as they're not having symptoms or visual acuity decline. I'm a little less tolerant of intraretinal fluid. If I see that, and especially if I see it as a trend, usually it increases just slightly each time if you're doing a treat and extend regimen. I tell patients that this is a trend that we don't want to continue, that if we let it continue, they're likely going to have a visual acuity decline if we go too long.
Got it. So, you made an interesting point. Your patients notice your visual acuity. In West Texas and Reno, they just asked me, hey, doc, what do you think is going on? We can't really rely on visual acuity. Is that true, Chris?
Yeah, this is, I'm about the least paternalistic physician on the planet. I'm a big believer in patient empowerment. And I'll often say, hey, we have these new drugs, and let me tell you the pros and cons. And these 90-year-olds from, Post and Slayton and Florida, Texas, that some of you guys have never heard of, they just say, doc, say, doc, what would you do? Just do what you want to do. And so, they're not as much fixated on vision. They're more fixated on how they function. And a lot of the decision-making is left to me, for better or for worse. And so, it's definitely, and I practiced in Houston where Christina is for 5 years. And it's a little bit different subset of patients that you get in a large metropolis like that, which is not to denigrate the people, the fine citizens of West Texas. It's just the reality.
Yeah. No, Chris, you bring up a good point. So has your practice changed in terms of choosing a treatment regimen or an agent because of the pandemic, or it really hasn't changed and you are just going for the durability, as you said earlier?
There's 18 or 19 of us now. We're spread across, Dallas, Fort Worth, Wichita Falls. And so I'm kind of, secluded here probably on purpose in West Texas. And so I'm kind of divorced with what the, bigger names like, Ash Abbey and, Wayne Solly are doing in our main offices. We all have our pet favorites. And so as a practice, we haven't adopted any sort of uniform position on drug choice or, follow-up visits. Although in Dallas, they tend to be a little bit more panicky about COVID than we were out here in West Texas.
Got it. So it sounds like your practice has not changed. It sounds like nobody's practice has changed in terms of managing patients, but we have all changed how we are running our offices and taking precautions to keep, our staff and our patients safe in this pandemic. So great discussion. Thank you to all three of you. We're now going to take a short break and we'll be back with a case in a minute. Hey everyone, welcome back to the first episode of Wet AMD, the art of drug choice and the latest data. Now we're going to have a case from Dr. Fuller. Chris, go ahead, present your case, please.
Sure. Thank you for inviting me, Arshad. This is an 81-year-old male farmer and widower who resides in a tiny town of less than 1,000 inhabitants in the windswept panhandle of Texas. In early 2014, well before my arrival at Texas Retina, he was referred with long simmering exudative macular degeneration in his left eye that had already pocked the macula with fibrosis. Avastin was given, which was effective in drying the retina, but the vision was little improved. Vision has remained 2400 and does to this day. And here you can see on presentation the poor non-subject eye at 2400, already with fibrosis and significant intraretinal fluid, nicely resolved after 4 Avastin, but with little visual gain due to the outer retinal architectural changes. Routine follow-up that November, again before my time, revealed neovascular changes that appeared ominous in the heretofore uninvolved fellow eye. You can see subretinal fluid and a focal area of leakage just superior to the foveal avascular zone in those photos. Visual acuity was 20/30 plus 2, and Avastin was given. The patient, and to this day, he does the same, burst of firm commitment to, quote, forever intravitreal therapy, and he dutifully submitted to a diet of either monthly or bi-monthly injection based on the vagaries of his fluid over the next several years. This patient remains very active. His daughter is a nurse who I know very well. He putters about in his tractor and still drives the small roads of his small town. And for the most part, even though I'm an Eylea guy, therapy largely consisted of Avastin because I saw no benefit in durability when I did switch him to Eylea on a few occasions. Again, for many years, monthly, bi-monthly Avastin proved a winning strategy. However, in the latter half of 2018, despite this dutiful compliance, the patient's vision began to flag and his retina became newly and increasingly wet, and it demonstrated recalcitrance to be healed by conventional interventions. By September of 2018, and he was certainly under my care at this time, vision in the right eye had dipped to 20/80. And this is meaningful and ominous in Texas because 20/70 is required in your better sighted eye to drive legally. So faced by this growing hillock of intraretinal fluid, Eylea was given in quick succession at monthly intervals, but did little to stem the worsening fluid and vision. Avastin was given 3 weeks later. I'll often give a, quote, superdose, either 1 or 2 or 3 weeks in the patient, but this also failed to be of any effect. Vision did improve to 20/70, however, the macular anatomy looked even worse. And here you can see in November of 2018, the patient had entered the realms of legal blindness. This was a 2200 eye with significant cystic fluid and a minute epiretinal membrane that had been present for some time and was likely not playing much of a role in the persistent fluid. So given this monumental cystic edema present in my love affair with Ozurdex since its introduction in 2010, I decided to use Ozurdex in this patient and gave it to him in late 2018. Lo and behold, a miraculous drying effect took place with a similar miraculous improvement in vision. Here, just, 8 days later, visual acuity had rebounded to 20/60 plus 1, and the patient was ecstatic. At that time, I did not dose the patients and simply chose to cautiously watch the Ozurdex disintegrate. But again, it was required on March 12th, 2.5 months later on May 28th, and then again at a 3-month visit on August 20th. We had begun to hedge our bets at that time, administering either Eylea or Avastin between Ozurdex visits, as I was fearful of a major subretinal bleed in an elderly gentleman on multiple anticoagulants who was a vasculopath. By late 2019, the patient's edema was again in full flower, and this despite being dosed with supplemental Avastin in October and November 12th. Beovu was recently approved, and I had a sample in hand, and I decided to try this new wonder drug. And I was very pleased with the initial results. Here we are at his 1-month follow-up. Visual acuity had improved by 1.5 lines with the excellent restoration of normal, nearly dry macular anatomy. The following month witnessed further visual recovery. He was now 20/60 plus 2, and also the restocking of Beovu in our clinic. Little did we know, but COVID was making its destructive rounds in China at the time, but few of us could have predicted the havoc it would bring to our country and kind of the shuttering of clinics and business as usual for many Americans. So I again administered Beovu and set an appointment for 7 weeks distant. However, this time Beovu was not as successful, although we did go longer, and the fluid returned. We returned to Ozurdex at this time, and again had similar happy drying results with improvement in vision. Visual acuity was 20/50 -2, 8 weeks after that Ozurdex, and this monocular patient, to his credit, has insisted on presenting in clinic every 4 weeks for supplemental therapy with Eylea between dose steroid. A 6 Ozurdex was administered in late June, and the patient's right macula remains dry and competently sighted at 20/50 at the time of this writing. He's still driving, and I saw him again approximately a week ago. And so our plan at present is to continue with Ozurdex on an as-needed basis with recurrence of edema, and to inject either Avastin or Eylea in the interim.
Excellent case, Chris. I tell you, very well management. So I have a couple of questions for you and the panel. So I'll start with Christina. So Christina, it's very interesting that you have a great response to Ozurdex as well as a great response to Beovu. It seems like there's like an anti-VEGF component to it, and there is an inflammatory component to it. What are your thoughts on this case? An excellent case from Chris.
Yeah, Chris, that was a great case, and I appreciate you sharing that with us. I applaud you for really thinking outside the box and turning to a drug that most people, I think, wouldn't even consider for somebody with neovascular AMD. I have heard of a handful of case reports, I haven't tried it myself, of people having success with steroid treatment. So obviously it worked great for your patient, and I think you really made a big impact, especially in a monocular patient. To me, pathophysiologically, it makes sense. You know, I think there probably is, we know there's an inflammatory component of AMD. Now, whether that's targeted in such a way with steroids, hasn't been looked at in a large study, and that's why steroids generally aren't considered standard of care in first-line therapy for neovascular AMD. But I totally understand, thinking about trying that in someone who's refractory to everything else and who's monocular, where there's really high stakes to lose. My question for Chris would be really, did you consider potentially another etiology of CME, maybe a twig RVO or something like that? I imagine you went through the list because it's interesting that it did respond both to anti-VEGF and steroids so well.
Yeah, absolutely. I do very few angiograms, but we did image him when he had the significant edema. I apologize for not including that slide, but I could deduce no other cause. I do have a handful of patients, and I wonder about this with early fibrosis, RPE dysfunction. Are those retinas more predisposed to becoming edematous? And in those patients, because he's not the only one I treat with twin therapy, I have some success. And again, maybe I'm missing some subtle second pathology, and it's certainly a good thought, but I didn't find any or detect any in this particular patient.
That's great. And the other thing I'll just comment on is, these monocular patients are a headache, because you don't want to take too much risk because they only have one eye, but you also want to do everything you can because they only have one eye, and that's what they're totally dependent on. So I think these choices can be really tough when you're faced with them, but great case. Thanks for sharing.
Yeah, you're exactly right. I'm a steroid swashbuckler, but even I have a little bit of pause in an elderly monocular patient sticking a 22 gauge needle. But so far so good.
Yeah, fantastic.
I think, and Nick, you're an excellent surgeon, and your skills are great. So I did see an epiretinal membrane when he started to develop cystoid macular edema.
I'll send him his way right now.
It's a little too far, but Nick, we see CME all the time with ERM, sometimes subtle and sometimes very tight. So when would you consider doing a peel on this patient? Obviously, it's a monocular patient, and we have to look at risk benefit, here. But what are your thoughts in patients in general who have ERM and have CME?
It's a great question, and Chris, a great thought-provoking case. Good job presenting it as well. I had a very similar patient who I see now probably every 2 weeks, and he was monocular. He had a membrane peel in his other eye at another institution that went poorly and does not see his 2400 or so in his other eye, and had AMD with a thickening ERM over time in his residual eye. And when I first inherited him from Paul Ternambi, he was about 20/50 or so. And we kept treating his AMD, monthly injections, and the ERM just kept getting worse. So we had the same exact discussion. It was much worse than what your patient here had. And I eventually did peel it. I had to wait until he got to about 200, I think is what we waited until. And now we peeled it, and now he's back at 2040. So it does go really well sometimes, but I applaud you for ignoring it. I think that's absolutely the right decision here. I do wonder if it's playing a role, though. I mean, it's probably irritating the surface of the retina, maybe, enhancing a little bit of inflammation back there. I'm sure it has something to do with the cystoid edema that's presenting there. I think it's fascinating that the Ozurdex was so effective, whereas the anti-VEGF injection really, at least besides Beovu, had very little effect. I was wondering a couple things. I was wondering if you brought the patient back 2 weeks after any of the anti-VEGF injections that did not work to see if there was any effect at all.
I very commonly will do that with patients that are poor or suboptimal responders. I'll say, hey, at 2 weeks, or at least getting a little fill-up here. And I did so with him and had no such, luck.
Okay. Or could you get Iluvien approved for somebody like this?
I have my secret dark ways of doing so. I am a huge Iluvien user. And we have discussed that.
Okay.
In fact, a little side note, his left eye, the lens went tumbling into the back of the eye 2 months ago, which has poor vision. I had to rescue it and do a Yamane fixation.
Yeah.
And now he likes that eye enough. He wants me to remove the floaters from this eye we've been discussing. And I said, absolutely not. But yeah, I do surgery occasionally on AMD patients with ERMs, but it would have to be pretty egregious, and it would have to hopefully be someone who wasn't monocular. That's I think, a big roll of the dice, especially when we're finding at least current satisfaction with Ozurdex periodically. But I love your thought about Iluvien. I've lobbied for Alimera to give me some samples so I can, play around with it a little bit, but no such luck to date.
Why do you think Beovu worked when none of the other anti-VEGF agents worked at all? What do you think's special about Beovu in this case?
I don't know. I've wondered about that. And again, it didn't work perfectly. He had a good first response at 4 weeks, but he had for years, he had a response with Eylea and Avastin. So I don't know if there's a component of tachyphylaxis. The ERM, as you mentioned, there probably is some kind of undercurrent of inflammation. And again, I was kind of privately disappointed that at 7 weeks, the fluid had recurred, but I wanted to go back to the winning strategy, as did he. So we kind of returned to steroid.
I mean, I think that goes to the point, Nick, of what I said earlier about having more drugs in the medicine cabinet, because we don't quite understand why certain patients respond to certain medications over others. Rolocizumab, as we've seen from the Hawk and Harrier trial, does have a better drying effect, it seems, than some of the other agents. So perhaps that's why. But I think there's a lot that we still don't fully understand about why certain people dry out and some people don't.
Hey, Nick, can I ask you a question?
Yeah.
You can educate me. This came up with a partner of mine in Dallas. If you were to operate on this gentleman and you saw the effect he had with Ozurdex, would you inject him 2 or 3 weeks before surgery to peel a flat macula, or would you just kind of go as is?
I would probably not do an Ozurdex right before. I would probably, if you're doing anti-VEGF, I'd probably get that on board 2 to 4 weeks prior to surgery. I would be worried. I have not done surgery when an Ozurdex been on board, but I would be worried about eating the implant during surgery accidentally. Some of you may have done surgery already with an Ozurdex.
Yeah, I've done that, Nick, and I agree with you. I think, you have to eat the implant. It's very hard to salvage it. That being said, I'm actually, Chris, a big fan of making the anatomy normal before I peel, so I don't have to put gas or end up with a lamellar hole or something like that. But great discussion, intriguing case. I want to remind our audience to check the images out from Chris's case on itube.net. I also want to remind our audience that there are more episodes are forthcoming, and that the next episode we will review phase 3 data in wet AMD. So thanks again to my great faculty here, and thank you for the listeners. This is the end of the first episode. Goodbye.